Welcome to the virtual trauma meeting. The aim is to provide a friendly environment for open case-based discussions with the help of orthopaedic trainees and consultants to build upon orthopaedic knowledge and experience for undergraduates. Please could you present the case for us?
The patient is a 94-year-old lady who's had a right hip injury. She fell in her nursing home in the early hours of the morning when she tripped one of her hair rollers and went down onto her right-hand side. She was on the floor for an hour, but was helped to a chair by the care home staff and then was brought in by ambulance. She also hit her head. She was unable to weight bear after the injury. She's got a background of multiple comorbidities. She's got AF, which she is on rivaroxaban. She's got ischemic heart disease with a previous stent. She's got a pacemaker in situ, and she's got chronic kidney disease. And she walks with a four-wheel walker, a maximum 30 metres indoors, doesn't go outside. She needs assistance with her activities of daily living, such as bathing, showering, and dressing herself. In the department, she had an AMTS of 5 out of 10.
For the benefit of everybody listening, an AMTS is an abbreviated mental test score. So there's a much longer mental test score, but the abbreviated one it's 10 questions to assess a patient's cognitive state.
And it's a mixture of basic questions about the patient, basic general knowledge questions, and then also a bit of dynamic, so short-term memory and attention. 8 out of 10 or above is normal, and 6 out of 10 or below is confused, and in the middle is borderline.
We do it on admission, don't we?
Yeah.
And when do we repeat it?
Then we repeat it every day post-operatively. Well, actually, we use a slightly different score now, which is a 4AT, but it's the same idea. And what we're doing is we're monitoring confusion because delirium is very common post-operatively in these patients. So they have a daily mental state test, and if there's evidence of delirium, we'll look for a source of the confusion.
The reason for doing it when they first come in and then repeat is to get a baseline, because what we're trying to distinguish between is whether they have established dementia or whether they become delirious during their inpatient stay, because that's very important to distinguish between the two. One needs investigating, one does not. Okay, so a few other things you mentioned there, John, in the presentation. You said that she was on the ground for an hour. Why is that important? Any thoughts from the floor?
Is she at risk of rhabdo if she's on the floor for a long time?
Yeah, so someone who's been lying on the floor, they can get a build-up of creatinine kinase, so muscle breakdown if their muscles had sustained pressure against them. And that could be an issue if she's already got some chronic kidney disease. That could cause her to have some acute kidney injury. So these are all things that we need to be thinking about. The other thing that slightly rang alarm bells for me was you said that she did hit her head, and then you said that she has atrial fibrillation and she's on a blood thinner. I didn't get which one, but why are alarm bells ringing anybody to the floor?
Is there quite a high likelihood that she's had a hemorrhagic stroke as a result of that?
So certainly she could have had a bleed in the brain, but not necessarily a stroke. But she could have a form of bleed in the brain. So what sort of investigation? I don't know if you've mentioned it, John. What investigation are we going to do in addition to these radiographs?
CT head.
CT head would be very useful. That's a way of picking up an acute bleed, and so that would be something that they would organise in the emergency department. As soon as you see hit head on a blood thinner, that means CT head is indicated, and that's an urgent thing that needs to be done in the department. Would anyone like to have a go at describing either of the two X-rays that are being shown? Do they look symmetrical? If you look at the one showing the whole pelvis.
So the right neck and femur doesn't look to be normal.
Yep, that's a very good start. So what we normally do when we're describing X-rays, we say what we're looking at in total. So this is on the right hand side of your screen. We're looking at an AP pelvis showing most of both proximal femurs or femora. Is anyone familiar with any lines that we look at? Does anyone know what on the right-hand side of the screen, looking at the left hip, there's a blue curve that I've just drawn on there. Does anyone know what that is?
Jensen's line.
Exactly right. I can't see who that was, but well done. Shenton's line. And as you can see over on this side, on the right hip, there's a disruption here of Shenton's line. It's not a straightforward curve, and you can see it where I've drawn over here that there's a fracture, and that's the fracture line I've drawn in there. Any thoughts as to what type of fracture that is in terms of? Let me rephrase that. Does anyone remember what the blood supply to the femoral head is? Does it go from the pelvis out in this direction, or does it come back up from the femur? So is it A or B?
Is it mainly B? But there's a little
B.
Lots of B's. Any A's? Very good with the B's. Good. So you're absolutely right. So it's mainly B's. The blood supply comes from the bottom up. So it's retrograde. Okay. It's all coming in from here. So do you think if there's a fracture in through there, is the blood supply going to get to this femoral head here with only a little bit? Yeah. So in an elderly patient, do you think that head's going to survive if you try and fix it?
No, well, it died from avascular necrosis.
Yeah, you could try and fix it. You could try and put it back in place and hold it there. But yes, the chances of it surviving, especially in the elderly, would be very, very slim. So we define them into intracapsular and extracapsular fractures. I'll just draw on where the capsule runs. So the capsule at the front of the femur runs down there. Can you see the green line, right? And it's slightly different at the back of the femur, but the blood supply is all coming in via the capsules through here. So this is an intracapsular fracture because the capsule is running from there to there. Okay. The capsule being the container that keeps all the synovial fluid around the joint. Okay. And the fracture's inside there. So it's an intracapsular fracture. We think in those terms, it's not trying to fix it is not going to work because it's lost its blood supply now, and this femoral head has had no blood supply for hours now, so it's not a happy femoral head. So what are our options if you can't fix it?
Replace it.
Yeah. So again, this patient falls into that category of patients with fragility fractures. She is elderly. She has had a low energy fall. She's broken a hip, which is normally a very strong part of the body, but it's particularly prone to fragility fractures. And again, we know from the evidence that if we treat this without an operation, it's not going to do well. It's not going to heal by itself, and she wouldn't be able to walk on it. So yeah, so we think about replacing this, and there are a whole heap of different people who get involved with the management of patients with fragility fractures because they have a lot of different needs. And so as orthopedic surgeons, we are just one small cog in the great wheel of fragility fracture management. So she'll be seen by orthogeriatricians, should be seen by nurses, should be seen by physios, occupational therapists, dietitians, anaesthetists, the whole perioperative crew. All of these people will aim to get this patient back on her feet and reduce the risk of further injury and reduce the risk of mortality and other morbidity associated with these injuries, because there is a high chance of dying as soon as you've broken your hip, and there's also a high chance of getting something else, such as a chest infection, kidney failure, a stroke, a heart attack. Any of these things can happen. So we're going to have a conversation with her and her next of kin about surgical management and talk about the options available to her. Now, what we talked about replacing it. So what are the two different options of replacing it?
There are a hemi and then a total.
Yeah, so a hemiarthroplasty or a total hip arthroplasty. How long do you think a total hip arthroplasty is going to last a patient?
Was it about 10 years?
Yeah, so the early ones were about 10 years. I'd say now that you almost expect them to last even longer. Some of the groups are showing hemiarthroplasties that have got 20, 25-year lifespans, if not longer. Well over 90% of them are lasting that sort of period of time. Do you think that's a good device selection for somebody who's, how old was she, John?
She was 94.
Yeah. So what we're looking for is something that's going to give her the ability to walk and be pain-free, that's not going to take too long. So hemiarthroplasty, you're just replacing the stem part of it, whereas a total hip replacement, you're doing both. So a hemi is just a monoblock like this, whereas a total hip replacement, you replace the cup and the stem. So there, in assessing any patient for a hemiarthroplasty or a total hip replacement, you want to know whether they are able to walk unaided or with the use of a single stick, or whether they have a diagnosis of dementia. Because if they've got dementia, then there's an increased risk of dislocating with a total hip replacement. So if they can't follow the instructions of the physiotherapists, that would be another reason to avoid a total hip replacement. And finally, if they're fit enough to survive a total hip replacement, it's a longer operation. It's got a greater risk of dislocation because of the size of the head in a hemiarthroplasty is larger, and so it's less likely to dislocate. But overall, it's the time, the length of the time of the operation as well. So they've got to be able to walk with a stick or less, no dementia, and have one or fewer comorbidities to be fit enough for a total hip replacement. Those are the three things that I'm thinking about.
Is age a consideration?
Age is not a consideration necessarily, but usually older patients don't fit into all three of those categories.
So the reason I'm pointing it out is because otherwise it looks like we're being discriminatory, when in fact this is it's a very balanced decision about what people will benefit most from against the risks to have it. We're trying to give people the best mobility for the smallest risk, and that's what basically that discussion's about. The reason I say that is often people think that we're making arbitrary decisions based on people's age and background, which we're absolutely not doing.
Absolutely. Good. So any questions at all on that? So that was a little bit of a look at intracapsular fractures, blood supplies to the neck of femur, and the difference between a hemiarthroplasty and a total hip replacement. Any questions? Anything not clear? Anything you want to go over?
So is a DHS, is that only for extracapsular fractures?
Yes, that's absolutely right. So a DHS is a dynamic hip screw, which is a form of a plate and a screw, which is intended to fix fractures. But essentially, what I want you to take away from this is, first of all, is it intracapsular or extracapsular? You know where the intratrochanteric line is, connects the two trochanters. That's where the anterior part of the capsule is. So is it intracapsular or extracapsular? If it's intracapsular, you're going to replace it. If it's extracapsular, you're going to fix it in the fragility fracture population.
Thank you for listening. We hope this has been informative. If you have any questions or suggestions for further programmes, please contact us at the Grand Academy at btinternet.com.